This computer. Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series, brought to you in part by a grant from the Iowa Oncology Society. And our guest tonight is my friend and American Cancer Society colleague, Dr. Arif Kamal. Dr. Kamal is the Chief Patient Officer for the American Cancer Society. Welcome, Arif.
Thanks, Dick, for having me.
It's great to have you here. Arif and I got to know each other about 2 years ago or so. How long have you been with the American Cancer Society?
Yeah, coming up on 2 years.
Okay. So tell us a little bit about yourself. So where did you grow up and how did you come to be Chief Patient Officer for the American Cancer Society?
Well, I would say in general, I think like lots of interesting stories. It's not a straight line nor sort of overly strategic. So I grew up in a small town of about 15,000 in about an hour or so east of Kansas City in Missouri. Small university town called Warrensburg that had a lot of farms, and the university was pretty much what it was. And I grew up there because my parents were both college professors there. They taught computer science, and it was a lovely childhood. A very warm and welcoming community that that really just, I think, formed a lot of who I am fundamentally. And then when I was in high school, I thought I was going to be a trial attorney. I thought, well, I'm a pretty decent public speaker. I'm going to go, argue for social justice and various different courtrooms in the country.
Did you debate? Did you do competitive debate in high school?
I did.
Yeah,
and
so did
I was
I.
pretty good at it. Yeah. And there was a certain dopamine rush that came with the challenge of really making a logical argument that would fly. And like so many people, the course of my life changed because of a cancer diagnosis. Now, not my own, but that of my mother. So I was a sophomore in high school, and my mom and my dad came back from a doctor's appointment that I didn't know really much about what was going on, and informed us. I'm one of three. I have a younger brother and sister, that we were gonna, as a family, go through a breast cancer journey together. And Dick, it was almost like clear as one of the clearest memories I have. My mind immediately said, "Okay, I'm going to become an oncologist."
Wow.
Not that I'm going to become a doctor. Not that I'm going to go into healthcare or learn about oncology, but I'm going to become an oncologist. And I set out to be a clinical trialist. I thought, well, okay, I'm going to cure cancer, and that's what's going to happen. And I went into medical school. I went to the University of Missouri at Kansas City, which is a 6-year program, combined undergrad and MD program. And during that program, her breast cancer came back in a pretty, remarkable way. And as that happened, as I went into residency training at the Mayo Clinic, her breast cancer became incurable. And I took care of her while she was on hospice for a short period of time. And then, obviously she passed. And that experience is really formative for me because I both didn't go into the oncology match, to become an oncologist. You go through this match process. I really took some time to reflect and decided that experience of palliative and end-of-life care for our family was not ideal, was not exactly how I wanted it to be. And yet I couldn't, with the right words and expertise, name the solutions. Well, okay, Arif, if it's not exactly what you wanted it to be, what could have been better? And I wasn't sophisticated to understand it well enough. So I decided to pursue a hospice and palliative care fellowship, and became the first hospice and palliative medicine fellow at the Mayo Clinic in Rochester, Minnesota, and spent an entire year learning about communication, about patient-centered care, about symptom management, and really about humanity. Because at the end of the day, there's a lot of suffering that can happen and does happen around the cancer diagnosis, not only for the patient, but for the family, their community. There can be mourning, there can be anticipatory grief, there can be a lot of uncertainty. And frankly, uncertainty management is one of the hardest things to do. And frankly, at the same time, as a clinician, so rewarding to talk to someone and say, you know what, I don't know the answer, but I'm really hopeful that this turns out well, and I'm here to support you. And let's talk through that.
Arif, where were you in your training when your mother died?
So I was a second year resident applying for fellowship
In internal medicine.
in internal
Yeah.
medicine. That's right.
Yeah. You know, our
And,
paths are somewhat parallel. My
yes.
mom was diagnosed with cancer when I was a junior in high school,
Right.
and she died of stage 4 lung cancer when I was a second year medical student.
Gotcha.
And although I would say I wasn't as perceptive as you were to realize at that time that it was going to shape who I was and that I was going to become a
Yeah.
cancer doctor,
Yeah. Yeah.
I now in retrospect realize that it isn't just coincidence that I became a cancer doctor, and that, you know, even after her death, I'm sure her hand was on my back, you know, every time I came to a fork in the road, that gently steered me toward, you know, what has become,
Yeah.
like you, not just a career in medicine, but a ministry of healing.
That's right. Yeah, Dick, that's what I think you and I are kindred spirits in that way. And really that transition for me from being this dream of being a clinical trialist, this idea of curing cancer is a very noble one. And I'm so glad so many of my colleagues, that's what they wake up every morning trying to do. For me, that pivot was really about, caring about people and showing care and concern and compassion, in the ways, the gifts and tools that I have and that I've built and have refined and learned and gotten better at and so on. And that's really then been part, as you said, part of my ministry, which is teaching people how to communicate and how to listen and how to respond empathically and how to be present and how to be humble enough to know that there are plenty of things that we can't fix, but by listening and hearing and understanding another person can be part of the therapy, right? As it being a therapeutic intervention, not therapy in the psychiatric way, but being the therapeutic intervention.
You know,
So,
I'm sorry, but one just thought of a phrase
yeah.
that I didn't come up with, but is something I use often, and is what you're describing. Not every patient can be cured, but every patient can be healed.
Yes.
And that's what you're talking about right now.
Yeah. In my practice, so I then, learned a ton from colleagues at Mayo, and then came to Duke University to do my hematology oncology training, and then started the first outpatient palliative care practice at the Duke Cancer Center. And that's largely what I do clinically, is palliative care.
And
And
so you actually you did internal medicine, obviously, first, but then you did the palliative care fellowship
first.
before you did
Yeah.
medical oncology.
Yeah. And it shaped, I remember very clearly I was taking care of a veteran in the inpatient ward of our VA center. And, he had significant anemia, low blood counts, and prostate cancer. And it was very clear that the prostate cancer had moved to his bone marrow in his pelvis. And that's what was impeding his blood cells from being made. And his anemia was related to that, really sort of infiltration of the prostate cancer within the pelvis bones. And I remember very clearly, one of the attending colleagues said, "Well, let's go do a bone marrow biopsy." And, as a young, energetic oncology fellow, and we have to do a certain number of those, right, to be certified in doing them. I think 99 out of 100 times say, "Great, let's go get the kit. Let's do it." Having been trained in palliative care first, what the first thought that came to my head is, to what end? And how is this helpful for the patient for us to describe where the anemia is coming from? We pretty much know where it's coming from. Is this out of curiosity for ourselves? Is this in service to the person? What if we cause some pain? And, I think it changed the way I think about distress. And, in palliative care, just like I think in lots of other medical specialties, and when we think about idealism in medicine, questions like, what does a good day look like for you? Mm-hmm. And as I thought about that, I thought, for this poor gentleman, a good day didn't mean that we were going to put a needle into the back of his pelvis. And, it shaped it. And I think that having done that training first really shaped the way I saw all of my oncology training, because I saw it through the lens of person first, right? Oncology intervention second, because I was trained in that order: person first, oncology intervention second. And it shaped a lot of other things that I did. And then starting that clinic and practicing in that way meant that I had this beautiful opportunity to meet with people, one, in the palliative care setting, not in 15-minute increments, but my appointments are 60-minute increments and 30-minute follow-up increments. And I could ask questions like, when you think about the future, what do you hope for the most? When you think about the future, what worries you? What keeps you up at night? Tell me about a good day. Tell me about a good memory. Hey, open your phone and show me some pictures that are really meaningful to you. And what's interesting is when I do that with patients, right? And I know, Dick, you do similar things with yours. I do that as my therapeutic intervention.
Mm-hmm.
That's not small talk. That's not shooting the breeze. That is the way we're going to make a connection. Because when I know that you've got grandkids and I see them in the picture and I see your face light up when you show that to me on your phone, and then I ask you, what's important to you? I think I have a good sense. And then what I can do is, now that I know who you are, then as we're talking about cancer therapy options, we could do this, we could do this, we could do clinical trials, so on and so forth. Then we can wonder together in curiosity, is pursuing that intervention going to help with spending more time with these beautiful grandchildren you showed me that picture of? And when we do it in alignment with a person's values, goals, and preferences, then the outcomes are better across the board. And I think that's what we're all here for as healthcare professionals, in that healing is we're healing and aligned to the values, goals, and preferences of the people we're taking care of.
Yeah, and as you said, that what some might think of as small talk is not small talk. It is obviously learning about your patient, their goals, their desires, their interests, but the act of having that conversation is therapeutic. And I would argue, in this world of worrying about physician burnout, I would also say it is therapeutic for the doctor as it is therapeutic for the patient. And to be able, as a physician, to have a practice that allows you to do that is so rewarding for the patient and for the physician.
Yeah. Well, when I describe it to folks, and maybe even some of your listeners would think this too, there is a certain expectation, like, isn't all medicine like that? I think people who experience the health system journey will tell you quickly, no, it doesn't work that way. But then people will say, but it should be, shouldn't it? And so when I describe palliative care specifically to people, oftentimes what they say is, oh, that's super interesting, because I just heard Dr. Kamal talk and none of that was about end-of-life care or dying. In fact, I haven't mentioned it yet, right? And we've been talking for a handful of minutes. What most people walk away is, ooh, I want that, right? I want my clinical team to approach me in that way. I might want to see a specialist who does that thing, but I want healthcare to have that ethos when it operates. And I think there's not enough palliative care clinicians in the country, and nor is that really the point. The point is changing collectively, and palliative care is one way of doing it, the culture of how we approach healing. And as we see people as people who have wants and desires and worries and hopes, that when we understand that, then actually medical decisions become clearer, because you see how they start to align, or we ask people, and so on and so forth. There was an interesting study, Dick, that looked at primary care physicians talking to patients about how often they interrupt the patient when they first start talking. I think you might have seen this, and I think it's like 11 seconds. I'd say, have a seat, tell me about what's going on, and and then we jump in. And I think that when certainly in palliative care, but even in good oncology practice, right, when you look at the ratio of who's doing the talking in the room, it really should be one where the patient is leading. And we think about shared decision making. That's a term that's oftentimes used. Palliative care, that's, I think, inherent to what we try to do, shared decision making. But what's important is, as I talk to colleagues about this, is there's a pendulum maybe that swung. And earlier versions of medicine were arguably very paternalistic. And the pendulum was really that the clinician is the expert. They will tell you what to do, and you will listen. And I think in certain, westernized versions of medicine, particularly in majority populations in the US, that remains not the way people want to do it. Now, there's certain cultural approaches that are very much deferential to the physician, and that's important to know. But for most delivery of Westernized medicine, actually, then the pendulum swung the other way, which was around what I call sort of the Chinese takeout menu of medicine, which became there's option 1 through 127 on a piece of paper. You pick what you have. So you come and tell me you have metastatic melanoma, and I say, well, here's the 7 things we could do. Tell me what you want to do. And as we thought about patient-centered decision-making, I think some people incorrectly interpreted that that's what was going to happen. And that's neither satisfying to the clinician, because we have a lot of expertise we should bring to the table. But also for patients, it wasn't actually meeting their expectation either, because the expectation is not give me all the information and then in the absence of context or recommendation or anything, that I'm going to make a decision. That's not what people wanted. So the pendulum, I'm going to argue, swung all the way to that, which was sort of this, kind of unfacilitated autonomy, if you will, right? Sort of like, just here's all the things, and I'm a waiter, and you're eating at my restaurant. I'll tell you what's on the menu, and you have to pick. And I think that when we talk about shared decision making, the pendulum, I'd like to think it swung towards the middle. And the analogy I make, Dick, is and it's not the perfect analogy, but I'll share it, is really to like a really nice dining experience. And if you think about how in that context you may talk to the person who's telling you about the menu, right? What are the options? What are the specials? But they also might say, what are you thinking about? What are you in the mood for? What catches your fancy? Tell me about that. And you might say, well, I'm really into seafood. Oh, that's interesting. And what kind? Well, I don't like a fish that's too fishy. You know what I mean? Okay. Well, we've got a really great sea bass. It was flown in yesterday, right? So why is that different than how healthcare is delivered today? Well, I'll tell you one. Why is because at least that person's asking you your preferences, what's on your mind. But importantly, what they're also doing is making a recommendation. And key to shared decision-making is not just providing options, but it's saying, based on me knowing who you are, I might recommend this option. Did I get that right? And there's a curiosity, there's a back and forth, there's a conversation that's happening, which fundamentally, I think all of us kind of go, yeah, that feels right. That feels like how it should happen.
Yeah. Yeah. I use similar language. I don't think I've ever used the restaurant analogy, but probably a dozen times a day, I will tell the patient, you're the boss. I work for you, but my job really is to make sure that you understand everything that's going on and what the options are and what would be best for you. Yeah. So as you know, once you develop that relationship, it almost always comes down to the patient also wanting to know, right? What would you do if I was your mother, if I was your brother? Sure. What would you do? And so there's very few patients that ultimately want to just choose. Once you have this caring relationship and they know that you care about them as a human being, they really are interested in what your thoughts are.
Yeah. And I think about, relationships, right? There's, to overly simplify it, there's 2 kinds of relationships. There are transactional relationships and there's relational relationships, right? Transactional relationships are, you have something I need or want, right? Transactional relationship might be like, you go through the drive-through at a fast food place and, you have something I need and I'm going to give you something in return. That's purely transactional. And, there's some folks who might ask the person's name that they're ordering the food from, right? You're trying to, right? But fundamentally, relational relationships mean that you have something in common and you've identified what that is, right? The commonality and alignment around that commonality is really important. And you'll see that people who do that, who, might be on an elevator and say, gosh, it's really cold outside. Oh yeah, I forgot my gloves today and blah, blah. What are you trying to do? You're trying to relate is what you're trying to do, right? You're trying to find something that you can both relate to, and that might create a relationship. And even then you might think after getting off that elevator, you might go the rest of your day. And then when you get on the elevator to leave for the day, you might go, that was that person I talked to. Like you actually remember that interaction because of a commonality that existed. And I think oftentimes when people think of healthcare delivery, it comes across, or it is, transactional. You have something I need. I have to see 30 patients today. You're number 16 of 30. And, I have a cancer and you need to give me chemotherapy. And so we're going to set up this transactional relationship. I have something, you have something, we're going to get together, we'll do that. And I think that when we get in a rush, when we don't take deliberate steps to create relationships, that it is transactional, because that's where it's going to start. really good clinicians and really good patient interactions with clinicians I see involve finding those things where you can relate. And what it is not, to be clear, is the physician talking about themselves, because that's actually not the way to do it. It's like when a patient says, oh yeah, we're going to Disney World, and you go, oh yeah, here's where you should stay. I went, blah, 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 blah. And, that's not, I don't know, completely helpful. But, when you talk about someone's values and preferences, what you're saying is I fundamentally know I want to understand who you are, what makes you tick, how you make decisions, so on and so forth. And then I'm going to align to that. And our relationship will be based on me understanding that and me meeting your needs in how I'm going to present, let's say, information to you, or how we're going to make decisions together. That makes it a true relationship. And I think in healthcare, there's this tension to kind of move from the transactional components, particularly as healthcare has become a bit more commoditized, a bit more centralized, aggregated. You've got big corporations that run it. Most of healthcare is run by big corporations, many of them privately, publicly traded, et cetera. That sort of like, we're here, we're in it together, we're creating a relationship and so on, I think can get lost, particularly as we get in a hurry.
Yeah. And what doesn't get stated, and what most patients don't know, is this conflict of interest on the part of the physician.
Yeah.
In a transactional relationship.
Yeah.
In the most callous of terms, is the physician selling a treatment,
yes,
for money to a patient. Now, it might be paid for by insurance, but the whoever is organizing the business, is organizing a business that is expecting a return on investment, and very close attention is paid to how much revenue is coming in. And a physician, or overachiever, wants to be successful. And the monthly doctor meeting, looking at who's generating what revenue, there is a tremendous conflict of interest that the treatment that may generate the most revenue, which may be totally appropriate for the patient, may be not the right treatment for that patient's goals, aspirations, and interests. And it's never stated as a conflict of interest. When you go to buy a car and the dealer is showing you the various lower cost cars and the fancy cars, you know that there's the more expensive car you buy, that the salesman's likely to get a bigger personal bit of that. In healthcare, I don't think most patients understand that the same process in a fee-for-service is taking place. Mm-hmm. Is that something that you are concerned about in terms of the state of healthcare? And do you think other models that aren't specifically related to compensation based on the treatment might help promote more relational doctor-patient relationships?
Yeah, I do. And if you look at national data, even with that, right, Dick, that there are plenty of patients who aren't getting, sort of the best or the standard of care. So it's not even assumed that if you take a lower cost option, that it's inferior care. And in fact, often.
Right.
And, I think we're at this unique intersection between concerns about care rationing or suboptimal care, in the name of cost savings, right? Which not sure anyone's really interested in. But I think what most people are surprised to hear is when you say, actually, sometimes the best option is not necessarily the most expensive one. And really good examples exist, let's say, in how care is delivered. So for example, the majority of people with advanced cancer get admitted to the hospital sometime in the last year, let's say, of their life. And yet we know from data from palliative care interventions that that's not necessarily necessary, that they're avoidable. And yet we know that those costs then become really high, not only for the system, but remember that patients are paying a component of that too. And frankly, society is as well, but someone's going to get a bill, right? And so it means that really good care can actually be less costly to the entire system and there are very clear ways to do that. And that, and not necessarily is the newest, most expensive thing going to be incrementally that much better. And I think that's where shared decision making is really important. And I think that in particular, when we know that a third of patients with advanced cancer either end up declaring bankruptcy or using up their entire life savings, I mean, truly liquidating their 401k, selling their house. I mean, that's pretty, dramatic to have to do. That if that's the case, which it is, and right, health bills are the leading reason for personal bankruptcy in the United States, right? Leading reason for personal bankruptcy. So if we know that to be true, it means that patients in particular and their caregivers should feel engaged to bring this topic up when they talk to their clinicians and ask the question, because it will shine a light on the idea that maybe we should look at other options or more options. And what it does not need to be is an apology or a self-indictment about someone's personal situations. The reality is that financial resilience is just a function of time, right? You may be personally a millionaire, but if I give you a neuroendocrine tumor for 20 years, I can tell you I'm going to change your balance sheet, right? I will do that. So, social determinants of health, as we talk about it, is just a function of time. For some people, it's an immediate issue today because of circumstances that they're in, and for others, it's changing. And as we know, for many cancers, fortunately, because of innovations, they're becoming chronic illnesses. For many, not all. And what that does is it means that the nature of distress can change, because you might say, well, if this cancer exists for 6 months, my life won't change all that much. I'll do this thing, I'll be done. My finances will be great. My relationships will be great. My social connections will be great. But if I said, well, now it's going to be 6 years, I can promise you that your social connections and your relationships may change. Your financial situation may change. Your long-term side effects may change, may become debilitating because now you're getting treatment for 6 years instead of 6 months. So there's a lot of things to consider over that longer period of time.
Yeah. And just to reinforce something you said, and it's not that the most expensive treatment is the best treatment, and that in many situations, less expensive treatment may be superior, not only in outcomes of the cancer, but also in minimizing side effects. I mean, we think of, the classic situation of a low-grade organ-confined prostate cancer, where the treatments can be active surveillance, a course of radiation therapy that's quite expensive, or a radical surgery. The New England Journal just this year published a 15-year follow-up study done at the United Kingdom for those patients with early stage, and lo and behold, randomized to active surveillance or radiation or surgery, 15 years of follow-up, no difference.
No difference.
And huge difference in the cost of each of those three, and a huge difference in the side effects that patients experienced. So in that particular study, for that group of patients, the least expensive treatment ended up being superior in terms of equal control of the cancer or survivorship, but much fewer side effects and less financial impact.
Yeah, that's a great point. And, just to dispel a myth, because I think it's important, you and I are talking about something that's very familiar to us. It may seem to reason that if drug A leads to someone living longer 1 year, and that drug B comes out and it costs twice as much as drug A. If I gave people multiple choice tests and said, well, if drug A costs whatever and leads to a year, and drug B is twice as expensive, how long will someone live on drug B? Most people, I think, would be tempted to say, well, 2 years then, because it's twice as much. But the reality is that's not the case. That there is very little relationship between a drug price, relatively speaking, to the next best thing. And the next best thing might be, the better thing might be 1 year and 1 week. And the first option is 1 year exactly, and one is twice as much expensive. And you look at it and say, well, if you look at the study was, 98% Caucasian people who live in Denmark. And so you ask yourselves a question, if you're an African-American person living in rural Iowa, does that apply to me? I don't know. But, once we start to recognize that drug pricing in particular is not rationalized to relative benefit compared to the next best alternative, then we can start to make it very prudent for all of us to be talking about it, particularly patients, to say, hey, I want to make sure I'm getting the best thing, but I also want to make sure that these things are important to me. Maybe the ability to put my children through college and all these other things. These are also important to me. How can we find the right treatment plan that takes all those areas of importance and kind of considers all of them at the same time?
Right.
Because I don't think it's an either or, right?
No.
I think it's going to be both. Yeah.
And especially in the setting of incurable cancer.
Sure.
So in the setting of incurable cancer, treatment A, B, C, or D, none of them are going to cure the patient.
That's right.
And sometimes the difference in statistically significant improvement in survival, as you pointed out, may be weeks.
Yes.
It's fair for the patient to know that, especially if the financial toxicity of one treatment is huge, and they really do want to leave something to their heirs, that to take the most expensive treatment with the idea that it might have a week or two longer survival in an incurable setting. Most patients, if they understand clearly what the goals and expectations, again, going back to the very beginning of our conversation, knowing the patients, knowing their desires, being open and honest with them about the choices. I think especially, for those patients who have a treatment that is a cancer that is treatable but not curable. Too many times, you and I have probably seen patients that don't understand philosophically that they're in that category, and sort of think that, okay, this treatment has stopped working and we'll go on to the next one, where philosophically they kind of still think that they're on a path that might lead to their cure.
Sure. Yeah.
How do you have that conversation without taking away all hope? How's the process by which you're seeing a patient with stage 4 lung cancer, brain metastases, bone metastases? Maybe that was their stage on initial diagnosis, and you're in the process of getting to know them. You're helping them figure out what the first line of treatment is. But you want to be open and honest about goals and expectations. What's some of the language you use in that first meeting? Obviously, you get to know the patient, and your language depends on how you perceive the patient. But to get across that concept of your cancer is very treatable, but based on the treatments we have now, it's not curable.
Yeah, I think that curiosity here is key, and it's not about, the point is not made when the information is delivered. The point is made when the information is understood. And it's really important to understand the delta between those two things. So I think, as a clinician, as communication techniques, check-ins are really important. And so what I might do with the patient is say, here we went over the scans and the stage and stuff like that. And I might ask a question like, and this is a probing question, like, based on what I've shared with you, are you, what are your thoughts about how serious this is? And that's a bit of a warning shot, because I will tell you that I've had a patient where I said, this is stage 4, and I was maybe admittedly in a bit of a hurry. So let's just say that. And they said, serious? Oh, well, it's only 4, right? Because there's 10 stages, right? Oh, okay. So when I bring up the word serious, what it does is generally people pause, because we might be kind of having a, lively or lighthearted discussion. I might say, well, based on what I shared with you, tell me about your thoughts on how serious this is. And they say, and then, for others, they'll say, oh, I get it, Dr. Kamal. My aunt had stage 4 lung cancer, and, I know there's lots of new treatments, but I get it. We can't take this away completely or cure it, but I know we can treat it, and I want to know what that is. I think the, other kinds of questions can be I statements. and they can demonstrate care and concern. So I might say to a patient, because this is stage 4, I'm kind of worried about how things are going to go. I'm very committed to helping you, but I'm a bit worried about how things are going to go. And then I sit in the silence. There's not a question there. And sometimes with that prompt, a patient might tear up and say, me too. I love my grandchildren, as I showed you their picture, and I'm just not going to get to spend as much time with them as I had hoped. Okay, I see where you are. They might say, you're worried. I'm not worried about anything. I think everything's going to go great because, I've got this promotion coming up in 2 years and we're going to retire in 3 and da-da-da-da. And I go, oh, okay. And, I think that sometimes healthcare clinicians, we might presuppose that someone's in denial. Oftentimes I hear that this person's in denial, this person's in denial. I don't know. I tend to think people are pretty sophisticated. I think that oftentimes we just haven't communicated very well. So I take that on my shoulders as sort of saying, oh, I'm not sure. Maybe I shared this information correctly. But when you use I statements, what it does is it says, well, if he's worried, then maybe I, as the patient, should be paying a different type of attention here. And when I say, I'm worried, it means I'm aligning with you. Because why else would I be worried? And if I didn't care about you as a human being, I wouldn't be worried. I would say, well, I'm worried I'm running short on appointment time here and I need you to get my next patient in. So, I think there's that. I might also say in a different way, like, I'm really hopeful with how serious this is that we're going to be able to get this under control. And what they hear is not me saying the word cure. And so they might say, well, what do you mean? Aren't you hope that we're going to cure this? And so what I've opened is a conversation, but I've started with an I statement so that I've put it on me. And not said something like, well, now that this is incurable, how are you feeling about it? That's a very, it's a somewhat inviting statement, but it can be a little aggressive because you're putting that person on the spot. So I put myself on the spot and see how they respond. And here's the reality. I think really good clinicians understand that, understanding seriousness of disease is a process. It's not an event. And for some people, I've, been at the bedside of dozens of people who have died and I've taken care of, and I've been there to watch them take their last breath. To me, it's about supporting them. There are patients to me who have, in their last minutes of their life, looked at me and said, I'm still going to fight this. You know that, Dr. Kamal. And I'm like, yep. And I'm here right with you. There is an understanding, 4 eyes meeting each other. When you see that person, they know what's happening. And I think oftentimes we don't give people enough credit because they're going through the lived experience. So that's why I have an anaphylactic reaction when I have learners tell me, oh yeah, Dr. Kamal, she doesn't get it. And I go, hold on one second. Let me talk to you 1 second. You don't think she gets it? She's living this every single day. You don't think she gets it? She gets it, right? The thing is, it may be that we don't get her yet, but we'll get there. And I think for some people, even when they're dying, they get it, whether they want to acknowledge it or whatever. That's a different thing. And so I think when we talk to people about code status and various other things, and I have learners tell me like, oh, they don't understand. I'm like, no, I think they do. They understand it in their context. It may be that we're not curious enough to have addressed the question that they have in their head, and that's because we haven't probably asked it correctly.
Yeah, good point. I can't believe how fast the time's going by. I do want to talk a little bit about your vision, the American Cancer Society's vision. You are the first time this title has been used, Chief Patient Officer, and it's not surprising that they brought on someone like you that is both an oncologist and someone trained in palliative care, who is used to, or whose whole essence is about patient-centered care. And tell me a bit about the American Cancer Society's role in helping our country develop this philosophy of care that is patient-centered.
Yeah, the American Cancer Society is an amazing organization. I think people know that. You and I believe that. I had known that as an oncologist for a long time. But in taking this role, I've learned a ton about all the different ways that we help people. And I think oftentimes people know us as an organization that funds groundbreaking cancer research, and we are in fact that. We have contributed to the reduction in cancer death rates by nearly a third or so in the past 25 years. And we're the largest funder of cancer research outside of the federal government. That's absolutely true, and we are active in the state branches of government, the federal government, to move important policies and legislation. I think oftentimes we're under-recognized for how much high-touch support we provide to people who are going through a cancer journey or at risk for cancer. And so every year we touch about 55 million unique lives across the country, and frankly across the world as well. And I've envisioned what I have the privilege of leading, which is called the patient support pillar in the American Cancer Society, as being problem solvers for good. And what I mean by that is, like I was saying earlier, is that any person at risk for cancer or going through a cancer journey will run into an obstacle. Doesn't matter what your means, who you know, where you live, you will run into an obstacle. That is 100% certainty. And even for my wife and I, who might live a very privileged lifestyle, we have small children. If she or I got cancer, I mean, who's going to take care of our children? Who's going to kind of keep the house moving forward? Who's going to, provide transport back and forth, plus the kids and so on and so forth? Like, those are things that every person faces. I will also add that loneliness and social isolation is also more common than people think in the cancer context. So, this is not an issue of money or means, though lack of that can exacerbate the issue. Mm-hmm. This is the fact that a cancer diagnosis in and of itself creates a lot of complexity in a person's life. And I see the American Cancer Society and the patient support pillar as 3,000 dedicated women and men across ACS and 800 who provide the direct help that I oversee. In being problem solvers, we do it by figuring out where the problems are. Now, the majority of problems that tend to show up are related to logistics, like lodging, transportation, like how do I get to the right care? How do I stay there? If I live in rural Missouri, like the town I grew up in, look, my mom's cancer care, as I said earlier, was an hour and a half from our house across these country roads. I was a high school student. My mom didn't love me driving on the highways. She didn't want to drive either. It was far away, and we were undergoing radiation. It was like, the 5-week standard kind of, and going back and forth was going to be too tough for a lot of reasons. And frankly, we grew up with very modest means. So the gas itself was going to be really problematic. So here, so we stayed at the Hope Lodge in Kansas City, Missouri, which was the nearest one. And the Hope Lodge, we're building our 32nd one. We've got these communities across the country. The idea is to provide no-cost lodging to anyone who's going through a cancer journey, plus their caregiver. We do not ask how much they make. Frankly, I don't care. If you have a need, we're here to meet that. And so every year we serve about 500,000 nights free for cancer patients across the country. We provide nearly 14,000 rides this year through our Road to Recovery program. Those are free rides provided by volunteers, just like potentially your listeners as well, to for people who need help getting to an appointment. We provide grants for navigation, our website. We have a call center. We get nearly 250,000 calls per year to our call center. It's 24/7. We're the voice at 2:00 in the morning when you can't sleep and you need someone to talk to related to your cancer. And we're growing that portfolio, right? We're starting to understand and appreciate those other barriers, childcare, food insecurity, loneliness, social isolation, caregiver resilience, and burnout. We're seeing important trends happening with increasing amounts of cancer care being delivered outside of large academic medical centers and in communities, in people's homes, in urgent care centers and places like that. We're seeing this, lengthening for many people, thankfully so, of the survivorship period or their active treatment period where they're on maintenance treatment. And that means that fundamentally the barriers they may come across may be different over time. So we partner with other organizations to help with paying utility bills, to help with paying food bills, to help with out-of-pocket costs. You mentioned financial toxicity, right? So if you're paying a 20% copay on everything that's happening, that can quickly get out of hand. We know the average person with cancer, at least from some data from a couple years ago, the unpaid medical bill on their breakfast table right now is about $10,000, right? So these are important these are important barriers that we as an organization are stepping up to solve. But here's the thing. we can't do it alone. The American Cancer Society is, a group of really dedicated women and men. But the way we do this is through volunteers like yourself, Dick, and other volunteers, right? Thousands of volunteers across the country who raise their hand and say, I want to help you do that thing. And I encourage everyone to go to cancer.org, our website, and sign up to be a volunteer. Look at the opportunities and spend an hour or two or a day with us to help improve the lives of others.
Yeah. And I'll say, obviously, you're an employee of the American Cancer Society, which doesn't diminish what you say at all. But I've never been an employee. I am a volunteer, and I will tell everyone that will listen that there is no organization out there in cancer field that that walks the walk. In addition to talking the talk, there's no organization that does as much to not only fund research, but to actually do meaningful things, not just for the patients, but also for cancer doctors and for the science of oncology and research. So American Cancer Society, over 100 years old, is just a phenomenal. So if you're interested in doing something in volunteering, there's no better organization to volunteer for than the American Cancer Society to do something real and meaningful for patients.
Well, thanks, Dick. And I'm going to brag on you for a second because you've been a stellar volunteer. You've been just an example of taking, those opportunities that exist and really leaning into them. And I want to thank you also for really teaching us as an organization how we can lean into the humanity of that delivery. You've taken volunteers from our organization into your programs as well, and taken them halfway across the world to do some pretty neat and interesting things. And I want to thank you because, it's folks like yourself and other volunteers we work with who teach us how to be better, helpers and problem solvers out there. Because, the thing is, we're going to reduce distress together. This is not the story of the American Cancer Society. This is the story of America, frankly. Mm-hmm. This is a story of the 2 million people who in 2024 will be diagnosed with cancer. An average of 5 of their caregivers. So you're talking about, right, nearly 10 million people who will be affected. You've got nearly 19 million survivors. I challenge anyone to not think of someone who they know in their immediate circle who's going through a cancer journey, either recently or right now. And so it's all over. And yet oftentimes what we don't talk about is okay, how do we make people feel better where the intervention is not a pharmacologic intervention? Mm-hmm. There's a lot of great science that's going on, but the average person out there is not sitting in a lab right now helping pharma move that forward. That is happening. That's beautiful. And we fund that research, and the federal government funds that research. But to the average person who's like, I want to be a force for good, how do I do that? Dick, you're a great example of that. There are, road to recovery drivers across the country right now who are doing that. We just launched an app called ACS Cares. In that app, CARES, it's a free download. In that app, a person can sign up to become a community navigator, a peer-to-peer navigator, where they can reach out to another person like them and say, I'm here to help you because we've got something in common. I was talking about relationships, about being relational. We have something in common. I'm also from Missouri. I'm also African-American. I also have prostate cancer. I am also a military veteran. All those things that are, commonalities between them. Let's connect those folks and get them to talking and say, okay, you know what? Let's demystify this. Let's get you another friend so you feel like your social circle is getting bigger, not smaller, while going through this journey.
Yeah, that's an exciting new program that you're developing.
We're really excited. It's the first time ever ACS has had a patient-facing app in 110 years. And apps aren't the solution to everything. We've got a great website. We've got a great call center. And for people who don't want to call us or go to the website, that comes to place. But, I think we as an organization strive to be helpful to everyone. And that's my vision. That's Dr. Knutson, our CEO's vision, is anyone out there so that no one feels alone is why we exist. And the burden of cancer is too gosh darn high. And that's why we exist as an organization. And that's why we work so hard to partner with others, because until that goes down, we're going to, just like you, spend our nights, weekends, and holidays. Well, for you as a volunteer in particular, for me, maybe during my day and some of the weekends, really, leaning into how do we appreciate these issues and frankly, be at the side of people and to solve them. And I think fundamentally these are solvable problems. We just, it's just accessing the right heart, the right resources, the right passion, time, and energy, and putting it together, where 1+1 = 3. I mean, that's just how we have to do it.
Well, Dr. Arif Kamal, thank you so much for being our guest this evening. But even more importantly, thank you for your leadership. I just am so excited that someone with your values, with your training, with your heart and compassion is leading the pillar of patient support for the American Cancer Society. Thank you for all you do.
Dick, right back at you. You are an inspiration to me and to many others. So keep up the great work that you're doing. And I love that we're partnering, and I hope we continue to partner for a long time into the future.
Amen, brother. And
All
for
right.
those of you watching us right now, if you know someone that would benefit by watching this program, it will be available tomorrow on the Above and Beyond Cancer website, YouTube channel, and the MercyOne Cancer Center website. So I hope you'll join us again next week. Thanks, Dr. Kamal, and thanks everybody for attending, and we'll see you next week. Bye, everyone.